Hello guys, welcome back to my YouTube channel. I would like to thank each and everybody who has shown their support and love towards me, and I am very happy that most of you guys have spent some time to watch the video, to comment on it and to share it. And I request everybody to please like the video, share the video, and please don't forget to subscribe the video if you like my content. And now we will start with the concept of ECG. Let me be very clear guys, ECG is a very complex topic and it cannot be done in a single video. So I have decided to make it in parts where I will be covering from the basics of the ECG to identifying the abnormalities in the ECG. So everybody please spend some time, some 10 to 15 minutes for each video to understand the ECG, because ECG is better understood than better remembered. If you have understood the ECG, you can identify any pathology you want. If you have the basic concepts, you can rock the ECG. So let's get started guys. As I promised you, I'll start with the basics of the ECG, the 0th level of the ECG. In the last video, we have discussed the mechanical activities occurring in the heart, like rapid ejection phase or isovolumetric contraction. And for the heart to contract, it needs the electrical impulses, right? The electrical conduction, right? And these electrical conductions are represented as ECGs. ECG is nothing but electrocardiography. It is the graphical representation of the electrical activities occurring in the heart. Let's understand what is ECG, how does it function. We will get an overview of the concept which we are going to discuss now. First of all, when there are electrical events in the heart, these electrical events are represented as a vectors. That means if there is an electrical impulse transmitting from atria to the ventricle, it is represented as a vector. And these electrical vectors will create a potential difference. A potential difference is created when there is movement of the current. When there is a movement of the charge, a potential difference is created between two leads. And these potential differences are picked up by the ECG machine. The ECG needle will be deflected, and these deflections will create the electrocardiograph. That means whenever the electrical conductions are reaching the various parts of the muscle of the heart, these electrical impulses or the potential difference is picked up by the ECG machine and it is represented as a graph. From this, if there is any abnormality or any change in the flow of the current or intensity of the current, or if there is any extra currents generating in various parts of the heart, or if there is any blocks in the heart, there will be change in these electrical vectors, right? If there is any change, the potential difference will be changed, the deflections will be changed, and based on the change in the deflections, the abnormal ECG patterns are recorded, and these abnormal ECG patterns will help us in identifying the pathologies in the heart. So this topic will be discussed under the following contents. First, let us understand how a normal cardiac muscle will be excited. We will take one cardiac muscle fiber, we will see how the electrical activity is changing during repolarization phase or depolarization phase. And then we will understand what is the principle of ECG and the important sign conventions in the ECG. This is very important when we discuss the ECG. And then we will draw the electrical vectors in the heart. Initially we have discussed in a single muscle fiber, right? Now we will take whole heart and we will try to draw these electrical vectors, and from these vectors we will derive a normal ECG pattern. And then we will discuss about various limb leads and chest leads used in the ECG, and what is the role of each lead, and what is the concept of Einthoven's triangle and chest leads. And finally we will discuss the ECG patterns recorded by these limb leads. First we have to know how the ECG or how the graph is obtained. Then we can derive it to various limb leads or various chest leads based on their position. And finally we will discuss the abnormal ECG patterns, and I will be discussing only those patterns which are important for the exams. Let's start with the electrical activity in a normal cardiac muscle cell. Consider this as a cardiac myocyte, and the resting membrane potential in the cardiac myocyte is minus 90 millivolts. This means the potential difference between the inside of the cell to the outside is minus 90 millivolts, and the inside is negative, that is why minus 90. And when there is any stimulation, that is from SA node or from the adjacent cells, what happens is some sodium channels will be opened guys. Due to the stimulation, very minute amount of sodium channels will open, which leads to influx of sodium. This influx of sodium changes the resting membrane potential to minus 70 millivolts, and this 70 millivolts, minus 70 millivolts is also called as threshold potential. And when the cardiac myocyte reaches to its threshold potential from minus 90 to minus 70, suddenly many voltage gated sodium channels will open, guys. Lots of sodium channels, lots. This leads to huge amount of sodium influx. The inside of the cell will become completely positive now. So from minus 70 millivolts to plus 10 millivolts, this sodium influx takes this potential from minus 70 to plus 10, and this phase is called as depolarization. Depolarization means we are reversing the initial polarization. Initially the cell is negatively polarized, now we are depolarizing it to positive, and this is due to the opening of voltage gated sodium channels after the reaching of threshold potential. Now what happens? After this, depolarization sensitive calcium channels and potassium channels open. But we have to remember here that calcium is influx and potassium is efflux. Initially, the calcium influx will be same as that of the potassium efflux. So the influx will be same as that of the efflux. There won't be any electrical changes in the heart, as the number of cations going inside is equal to number of cations coming outside. That means based on the charge. And this phase is called as the plateau phase. This is the depolarization phase. After some time, what happens is this calcium channels will be decreased. The activity of potassium channels will be increased. This leads to opening of lots and lots of potassium channels, and there will be potassium efflux, potassium coming outside. This leads to the drop of the potential across the membrane, and this phase is called as the phase of repolarization. Repolarization is due to efflux of potassium due to opening of potassium channels across the membrane. And as we all know, there are large number of gap junctions present between the cardiac myocytes. Some of the sodium will reach here. This leads to the threshold potential. Suddenly the voltage gated sodium channels will open, leads to depolarization phase, plateau phase, repolarization phase. Like this electrical impulses is transmitted through all the cells due to the presence of more number of gap junctions in the cardiac myocyte. This is what happens in the electrical activity of heart, that is phase of depolarization. There will be a plateau phase where there will be some gap, and then finally the repolarization phase. Okay guys, now we'll start with the second topic, that is the principle of ECG and sign conventions. Let me be very simple guys. ECG works like a galvanometer. Whenever there is a movement of charge or there is a potential difference, then there will be deflection in the galvanometer. In the same way, when there is movement of charge inside the heart cells, this galvanometer will show deflections and produces the waves. For example, let me show in this diagram. This is a cardiac myocyte, and I put a positive electrode on this side and negative electrode on this side. Putting electrodes is your wish guys. You can put positive here and negative here. You will get an opposite direction wave. And this is the galvanometer, and I took this needle of the galvanometer out, and this needle will contain ink guys. Whenever the ECG paper is moving like this and this galvanometer needle is deflecting up or down, then we will get these waves. For example, initially the heart muscle is in resting condition. All the inside of the heart cell is negative initially. There is no change in the electric currents or electric charges initially. So there won't be any deflection in the galvanometer, and then we will get an isoelectric line. Whenever a stimulus comes, the cell starts depolarizing. The inside of the cell starts becoming positive. Then what happens? The positive wave is generated, and this positive wave is going towards the positive electrode guys. Positive wave going towards the positive electrode creates a positive deflection or positive wave like this in the ECG. This is the axis of the lead guys. The lead, negative to positive, is the axis of the lead. This is the direction of the electric current, and this is the, if it is positive or negative, we should be clear with it. And what, suppose if we take this example, what is happening here? Inside of the cell is completely depolarized, inside is completely positive, there is no electrical charge moving, so we will get an isoelectric line. In this example, negative wave, this is the negative wave is going towards the negative electrode. Whenever the negative wave is going towards negative, then also we will get a positive deflection. The ECG will move like this, creating a wave or positive deflection. Finally, if we keep the electrodes perpendicular to the direction of the electric vector, what happens? Till here, the positive wave is coming nearer to the positive electrode. So we will get a positive wave. After here the positive is going away from the positive electrode. If the wave is going away from the positive electrode, there will be a negative depression or negative wave. To make it simple, I have written these things here. When a positive wave going towards the positive electrode, we get an upward deflection. When negative wave is going towards negative, then also we will get upward deflection. Positive going towards negative or negative going towards positive will create downward deflection. Till now we have discussed the axis of the lead, direction of the electric vector, and if it is positive or negative wave, and all these factors influencing the positive deflection or the negative deflection. Now we have to consider two more factors, guys, which is the amplitude and the velocity of conduction. Amplitude of conduction and the velocity of the conduction. Amplitude is directly proportional to the thickness of the muscle, guys. Ventricle is more thick, so we will get a big wave. Atria is less thickness, so we will get a small wave in atria. So these things also determine the quality of waves, determine the type of wave generated in the ECG. And finally the velocity of conduction. If the velocity of the conduction is more, then the wave will be like this. The wave will be sharper. It will take very less time. If the velocity of the conduction is less, it will take more time to deflect. So the depolarization wave is like this. So these five factors influences the type of wave. For example, if I tell a positive wave going towards the positive electrode with high amplitude and high velocity of conduction, then the wave looks like this. And if you know these five factors, we can draw whatever wave we want. Okay guys, now we'll see how these electrical vectors are generated in various chambers of the heart and how it is reflected into the normal ECG. Consider this as a patient who is coming to our OPD to get his ECG done. We connect two leads, one lead to the left leg and one lead to the right hand. Positive lead to the left leg and negative lead to the right hand. Now the axis of this lead becomes this one, in this direction, that is downward and towards the left side. Now you can ask me, sir, why we are connecting these leads to the legs or hands? Electricity is generated in the heart, right? So we should be connecting these leads nearer to the heart, right? But our body is a very good conductor, guys. Whatever current that is generated here is easily transmitted to the limbs and anywhere of the body. We will try to depict the electrical vectors which are generated in the heart and correlate with the normal ECG. Let's come to the first phase or the phase of atrial depolarization. This electrical activity occurs in three phases, guys. One is the atrial depolarization, next ventricular depolarization, after that ventricular repolarization. This atrial repolarization is masked by ventricular depolarization. First this atria depolarizes and then current transmits through the ventricles. This SA node fires, guys. This SA node fires and starts stimulating all the atrial cells nearby. There will be lots of gap junctions between these cells and the electrical impulses are transmitted throughout the atria and the atria gets depolarized. These all are the vectors or electrical vectors created by the conduction. Now we will try to draw a net vector of this electrical activity through the atria during the atrial depolarization. This becomes the net vector of the conduction during atrial depolarization. The first electrical phase. See, now we have to apply those five factors. First thing is the direction of lead is this and the direction of the current is this and depolarization is a positive wave. Now a positive wave going in the direction of the positive electrode, we will get a positive deflection. And atria is a slow conductor, guys. The conducting velocity through the atria is very less because atrial cells are arranged like this in series and there will be more resistance to the current when the current is passing through these cells. There won't be any specialized cells in the atria like in the ventricles. Ventricles have a specialized cells called the Purkinje system where the cells are large and the resistance which is acted against the current will be very less. As the resistance is less, the conduction velocity through the ventricle will be more when compared to the atria. First is positive wave is going towards the positive lead and the conduction velocity is less, and finally atria is a thinner muscle, so the amplitude of the wave will be less. The first wave which is generated during the atrial depolarization is the P wave P wave is a positive wave, positive going towards positive, amplitude will be less as atria is thinner and the conduction velocity through the atria will be less. So there will be a broad wave. Now what happens? The atria is completely depolarized. But the atrioventricular septum acts like an insulator, guys. This full thing acts like an insulator. The currents cannot pass through this. The only way the current which can be passed from atria to the ventricle is through this AV node or atrioventricular node, guys. But this the property of AV node is it is a very slow conductor. Why the AV node should be very slow? Because as we have discussed yesterday, after the atrial contraction, the ventricular contraction begins. During the atrial systole, the ventricle should not contract, right? So the heart will give it time to the atria. The atria will completely contract due to the depolarization, and then this current transfers to the ventricles, and then the ventricles start getting depolarized. During these depolarization, the ventricle gets systole or ventricle contracts. So this AV node will create a gap between the atrial contraction and the ventricular contraction. Why AV node is conducting very slow? It has three reasons, guys. AV node has fewer gap junctions, less conducting velocity. There will be more resistance. The cells in the AV node are arranged in parallel arrangement rather than the series arrangement. So the current has to pass through lots of cells to reach down. So it will take more time, creating AV nodal delay. And finally, AV node is dependent on slow calcium channels. SCR node is dependent on sodium channels to get excited, but AV node depends on calcium channels which are slow. It takes more time to depolarize each cell. These are the three reasons why there will be a delay in the AV node, and the conduction velocity through the AV node is 0.1 meter per second. What happens when there is any delay, or what happens when there is no charge transferring properly? If there is no potential difference, there will be an isoelectric line in the ECG. This is the reason why the isoelectric line or PR segment is generated, because in this phase the current will be traveling to the AV node. When the current is traveling to the AV node, the conduction is very slow. It cannot be picked up by the ECG, resulting in an isoelectric line. Now atrial depolarization completed. Atrial repolarization is masked by the ventricular depolarization, and the current has been traveled to the AV node. Now the current comes to the ventricles. Ventricle undergoes depolarization in three phases. First one is septal depolarization, next major ventricular depolarization, and third thing is basal ventricular repolarization. This is the base of the ventricle and this is the basal ventricular depolarization. So we should learn these three depolarizations separately. What happens during the septal depolarization? This is the septum, guys, and these are the Purkinje fibers which are coming from the AV node or which are present in the ventricle. These Purkinje fibers are present in the ventricle. The septum consists of two parts, the fibrous septum and the muscular septum. The fibrous septum also forms a sheath around these Purkinje fibers, act as an insulator and prevent the conduction of these electrical impulses through this. There won't be any conduction through Purkinje fibers at this part, but in the left inferior region, the fibrous insulator is deficient. Fibrous insulator, it is like a wire, guys. That plastic insulator will be there around the wire side. In the same way, the fibrous part of the septum will form an insulator around the Purkinje fibers. In the left inferior part, the Purkinje fibers are not insulated by the fibrous part of the septum, so the current waves travel in this direction and gives electrical impulses to the muscular part of the septum, and the resultant vector is this one. The resultant vector due to the septal depolarization. The septal depolarization, we have to see the five factors again. It is positive wave going towards the negative electrode. This is the reference electrode. It is the positive wave going towards the negative electrode. So first thing is we have to get a negative wave, and this is a ventricle. Conduction speed is more in the ventricle. So sharp negative wave. And what is the amplitude? Septum is very small, right? Very thin when compared to this part of the ventricle, right? So we will get less amplitude negative wave. This is the Q wave. Q wave is the lesser amplitude negative wave which is generated due to the transmission of currents in this direction. And then second part of depolarization of ventricle, that is major ventricular depolarization. See, in this part of the ventricle we have two parts. This ventricle is divided into three parts. Sorry. This is the subendocardial. This is subepicardial part of the ventricle. First, this subendocardial part of the ventricle will get depolarized, and this depolarization wave will transmit towards the epicardium. The wave of the depolarization is like this. All this part of the ventricle depolarized like this, but left ventricular is thicker than the right ventricle, so the resultant vector lies towards the left ventricle. Vector, sum of the vectors is, we should add the magnitude and also the direction, right? As left ventricle is thicker than the right, the resultant vector will be towards the left side. This is the major ventricular depolarization electric vector. This vector is positive, going towards the positive, so we will get a positive wave. And then what is the amplitude? Amplitude is very high because ventricle is a very thick muscle. The electrical impulses or the current generated is very much, leading to higher amplitude of the wave. And finally, what is the duration? Ventricle is a fast conducting muscle, so the duration will be less. Here I have drawn it somewhat broader, but QRS complex will be very narrow when compared to P wave. R wave is due to the depolarization of the ventricle, the depolarization of major part of the ventricle. Finally, we come to the depolarization of the basal part. This ventricle depolarizes. When the currents are reaching the basal part of the ventricle, the current direction will be like this. The direction of the current will be, electrical vector will be like this. So this is positive going, when compared to this, positive going towards the negative. So we will get a negative wave. And what will be the amplitude? Amplitude will be less, as the basal part of the ventricle is very thin. And finally, what will be the conduction velocity? As it is ventricle, conduction velocity will be more. So again a small negative S wave, sharp S wave is generated. Till now, atria is depolarized, the current is transmitted to the AV node, resulting in the isoelectric line. Q wave is due to the septal depolarization, R wave is due to the major ventricular depolarization, and S wave is due to the basal ventricular depolarization. Now the ventricle also has undergone depolarization. After depolarization, there will be some gap between the repolarization. Why? Due to the influx of calcium and efflux of potassium being the same. So for some time there will be an isoelectric line, as there is a gap between depolarization and repolarization. This isoelectric line is due to the net charge moving in the ventricle is zero, like calcium influx is equal to potassium efflux. Now the ventricle starts to repolarize, guys. Remember, the last cell to depolarize is the first cell to repolarize. Which is the last cell to depolarize in this ventricle? This is the subepicardial part of the ventricle. This is the last cell to depolarize. So the repolarization starts from outside to inside, like this. Repolarization starts from outside to inside. The repolarizing vectors will be like this, outside to inside. And remember guys, repolarization is a very slow process. That means the wave in the ECG will be broader, and there won't be any differentiation between the septum or major part of the ventricle or basal part of the ventricle, as this process is slow, and we get a resultant repolarizing vector like this. This resultant repolarizing vector, repolarization is a negative wave going towards the negative side, so we get a positive deflection, and this positive deflection will be somewhat bigger and it will be broader, as the repolarization is a slow process. Have you understood? This is the reason of the T wave. T wave is due to the ventricular repolarization. Now we will recap all these phases and we will see what is the reason of each wave. P wave is due to atrial depolarization. PR segment or this isoelectric line is due to AV nodal delay. We know what are the reasons for AV nodal delay. Q wave is due to this wave. Q wave is due to septal depolarization. R wave or the major ventricular depolarization wave is due to depolarization of most of the part of the ventricle, which gives a very tall and narrow wave. S wave is due to basal ventricular depolarization. ST segment is the gap between the depolarization and the repolarization as shown in this, and T wave is due to ventricular repolarization. We will discuss the segments, intervals, and the duration of the segments, intervals, and waves in the next video, and we will be discussing the chest leads, limb leads, and normal patterns in those leads, and finally the ECG abnormalities in the next videos. Thank you.